Let me ask you something. What is care? In healthcare education, we use that word all the time. But what is it? My name is Veen, and in this episode we will discuss the article Because We Care, a philosophical investigation into the spirit of medical education. I wrote this article together with Camillo. It's the 8th installment of the Philosophy in Medical Education series of the journal Teaching and Learning in Medicine. And it will also be published as a book chapter in the edited volume that Cianciolo and I are working on now, which is called Helping a Field See Itself, Envisioning a Philosophy of Medical Education. In our article, Camillo and I argue that medical education should pay attention to the concept of care, in the same way that medicine does with the concept of health. In healthcare education, care is the most important and fundamental term. We use Being and Time, a philosophical work by Martin Heidegger, to suggest a conception of care that encompasses all its meanings, from empathy to advocacy to medical treatment and the infrastructure of healthcare. Camillo is a medical doctor from South Africa. Currently he works as a senior house officer at Letterkenny University Hospital Department of Hematology. He has a special interest in existentialist philosophy, German idealism and phenomenology. Camillo has also published a book chapter together with Sven Schaepkens called In Pursuit of Time, an inquiry into kairos and reflection in medical practice and health professions education. My co-host today is Dr. Adina Khaled. Adina is a general internist and the Stephen and Shelek Rule Endowed Chair of the Robert D. and Patricia E. Kern Institute for the Transformation of Medical Education at the Medical College of Wisconsin. I hope I pronounced that right. She has spent her career building the evidence base for ensuring health professions education produces excellent health professionals committed to and capable of caring for the health of the public with character. Yeah, so we're in 3 different parts of the world. Where are you, Adina?
Right now I'm in Milwaukee, Wisconsin, right in the center of our country, right?
And you're American?
I'm American born. I am a New Yorker, which is as regional as being from Holland or from anywhere. So I moved I grew up in New York and trained and did did 32 years of my career in New York. And then 2.5 years ago, I moved to Milwaukee to become the director of an Institute for the Transformation of Medical Education at the Medical College of Wisconsin. So I'm new to this location, relatively. And then of course, COVID made everything interesting over the last 3 years. So
yeah, and I'm a Dutch person in Holland, so that's kind of boring in terms of location and nationality, but I think Camillo has the most interesting combination.
Yeah, my mother's Dutch and my father's Italian, and then I was born in South Africa and studied there and worked there until December last year, and then I came across to Ireland in hope of sort of furthering my career in hematology. So yeah, I ended up here. It's cold. It's colder.
You're not used to this, are you? Cold and rainy. The Northern Hemisphere. So I have to say that that in our institute, we actually of the many activities we do, we're a very comprehensive institute, thinking and rethinking about transforming medical education. We have a laboratory that's focused on the philosophies of medical education transformation. And so I think that's, I'm very interested in your paper, but I'm most interested in talking to the two of you about how philosophical analysis kind of informs how you think about medical education. And I love the idea of caring as a lead. Our mission in our institute is to transform medical education to align with the needs of the public, with character, caring, and competence obvious to all. So this is very important. It's an important concept for me in my day-to-day work. So Can we start, Camilla? Tell us a little bit about your story in terms of your medical training, because I hope we're gonna be talking mostly about, why philosophy, but it would be nice to know your context first.
So I studied in medicine out in a small town in the center of South Africa called Bloemfontein. It's not especially impressive, but it is impressively poor. So and South Africa has these, I'm sure you've seen some of the pictures, has these incredible socioeconomic divisions that, really were formalized in apartheid and still linger. So we had quite, quite academic training and quite intense training, in the sense that it was aligned with sort of global expectations, but we were practicing medicine in places where, when it would rain, it would flood, and you would be practicing medicine in, 2 inches of water. You would still order your CT scans, you'd still have access to all this investigation, but also you would send patients home to live, in a little hut they built themselves. So it was really, it was quite a schism between, these international outlooks on education, that we really want to push our students to be academic, we really wanted them to be on the cutting edge of science, but also, the poverty that we were in, it was quite a disconnect. And then when I went on and did my practical training, so in South Africa, it's 2 years of internship and a year of community service. I did that in the poorer districts of Cape Town, lots of gang violence, and really the same thing. Fantastic training, high standards of academic knowledge, but also, we'd have patients who say couldn't get their insulin because people were shooting outside. So it was this crazy kind of, these two worlds where we were being trained to go into, Harvard Medical School or Oxford and, be on that level. But really, you can't work like that when you don't have, first of all, the equipment, and your patients aren't living normal lives. So it was really that incredible disconnect that started everything off. That's the disconnect that really started modern philosophy in some ways. Kant's critique of pure reason is really an attack on everyone before Hume, who was, constructing these beautifully sound philosophical castles in the sky, as we now call them. And that was really Kant's critique, is that we really have to have a philosophy that's based in substantial reality. So that was really, I thought philosophy during education, or at least during my experience, was always there, and it just sort of had to be unearthed. And I think that's where it started. I think there were a few other moments through, reading, going through the history of medicine, which is horrible.
Yeah.
The history of medicine is
many challenges in the history of medicine. Yeah.
Oh, awful. I mean, even I think it was just Holocaust Remembrance Day the other day, and right. And I think in around the 1960s, mid 1960s, when the Holocaust became kind of a cultural symbol, something that we all knew about as horrible, was really when the medical experiments were unearthed. That's the experiments of twins particularly. So, and when it comes to moments in medical history like the Tuskegee experiment that everyone knows about, the thalidomide, the history of thalidomide and how that created the whole FDA. These are massive moments in history, and they really can be quite awful. So I had these kind of questions that were really, how is it that in medicine, where we think we're helping people, we're also capable of the most insane cruelty? And then I had a second question, which was, how is that kind of capacity for cruelty already in medical thought, already in medical training. So this paper was kind of a critique. It was aiming at what is really behind medical thinking. So I think that's where it really began. And when I was looking at it, I came across Heidegger's particular concept of care and how that really gets to some of the presuppositions of where medical thinking really begins.
Right. So let me take you to the very concrete here in the paper for just a minute, just so we can, for the listening public, we can understand the case that brought this forward, or at least the one you share. And I'm going to read it out loud, and I want you to sort of, let's unpack it together. So you, somewhere in your career, I'm understanding this is a real case that you experienced, where there was a junior resident who was seeing a patient after hours as a referral from the emergency room. And the resident noticed that a blood test was required, as what we usually call in the United States routine admission labs, right? There were, but the patient was reluctant to have blood drawn and had had a series of unsuccessful blood draws, and it was obvious on her arms were bruised. She was restless and uncomfortable, and the resident was deeply empathic with that discomfort, so much so that the resident decided not to draw the blood. And then on the next morning, as is wont to happen all over the world, and as you said, in the ivory tower of medicine, on rounds, the attending asks for the blood test results, and the resident is at a loss. Now, you don't describe what that looks like, but it does. The one question is, does she admit that she didn't draw the lab? Does she explain herself, or does she even have that level of awareness yet about why she did what she did? But anyway, you go on to describe that the attending is annoyed, that decision making is delayed because the lab findings are not available, and that the attending seems to be judging the resident as not caring, right? As being careless. And then you go on for pages in your paper, and I recommend reading them in detail, sort of taking this apart in terms of the different ways in which care is present in this story. And I wonder, can you either take us back to that moment? Which role were you playing, and how did that bring all of this forward?
Well, I was actually a passive observer in this, and I was sort of between two people, and there were the details that are in reality were that this junior resident had actually made a lot of effort to get this particular patient, a series of investigations, opinions from different departments, what should be done. And when they came to this patient, they sort of, I don't know if it was conscious. I was just observing. I just noticed it, out of the corner of my eye, that they just didn't do it. And it was actually the receiving doctor, who's a relative of mine, who was really, irritated, because this is such a high pressure environment. Decisions have to be made, and they couldn't make those decisions because they didn't have the results available. And I remember talking to herself, almost out loud, how doctors tend to do, rather than confrontation. It was sort of just, does this person even care? And I had watched this junior doctor make a huge effort. And if that effort had been noted, these results might have even seemed trivial. But from the receiving end, I can also understand the position of the doctor receiving this patient, who has to now make a decision based on less than they would prefer. And so I think that it was interesting that the concept of care got brought up at this point. Does this person care? And I thought, yes, this person cares a great deal. But why was it a judgment and not a moment for sort of learning? Because this person did care, but they also had to be taught that the real crux of this case would have been contained in those blood results. So both of those things, both the effort and doing the bloods, were both caring and noticing that the patient is, uncomfortable and doesn't really want blood. But that also has to be addressed. That all has to come together, and that navigation that the junior resident failed to do, that's where education needs to step in, not step out and judge. So that kind of I use that example because I felt like it brought a lot about how to sort of raise the bar of actually where education stands in this mess of day-to-day medicine.
I mean, it's interesting to me in most of the paper that you stick pretty close to healthcare education, and you keep emphasizing that of those three words, the piece we understand least is the care piece. And I like this case because you could imagine from her point of view, from the resident's point of view, this was a values conflict. She was being asked to do something she felt was potentially wrong, hurting, causing pain, discomfort, without thinking, like you said, of the ultimate longer term manner of caring for this patient, which meant helping understand what was going on with the patient and then making good clinical decisions. And she didn't really have that perspective, or that perspective couldn't rise above this, what sometimes feels to trainees like a values conflict, right? How dare you ask us to hurt someone in pursuit of information that would help them ultimately? So sometimes people call this moral injury, which is interesting. I don't know if you're following that argument, which we're talking a lot about in our institute, which is, when physicians are asked to do things that don't feel right, how do you educate someone to get out of that moment, the particulars of the moment, and think more broadly about what caring means for this patient? What would you have wanted your relative, the attending in this case, to have done or said that might have accomplished that educational goal?
Well, I think it would have. I mean, that's a great question, and as all of your questions have been really fantastic. So I would say that this would be a teaching moment because the person doesn't understand, the person not doing the bloods, what the real crux, what the real underlying logic that care must follow in order for this person to receive what they need. And you see, there are these two kind of ways, these two kind of sort of spheres that I see, that I've been criticized of saying this, but for simplicity's sake, I'm going to stick to it. That in a way, there's these sort of empathy, not wanting to hurt someone, but also these like concrete physiological needs. And for most people, they can't treat their body as a set of concrete physiological needs. They treat it as kind of slightly in a mystical way, like something that they've been ignoring for years that has suddenly cropped up. That's the nature of illness. It's disruptive of our ignorance of our own body, and that's what makes it so distressing. But in a way, I was trying to draw those two spheres together under one kind of one kind of form of thought, which was that actually both the physiological needs and empathy are both under the realm of care, and so can be examined together as part of the same kind of thing. And so that's why I thought it was maybe not an interesting, that's up to the reader to decide. Yeah. But I felt it was an interesting way to sort of open up this to philosophical discussion.
What's interesting is and I'm just going to read back to you what the two of you wrote, but you asked the question, why do students care less as a result of medical training, right? So why are they taught to privilege one mode of caring over another? And it seems to be a moment, right? You're describing a moment where in that moment, the educator, and again, that attending is wearing many hats, but one hat is to educate that trainee. Has to balance, like you said, has to balance those two. Maybe doesn't even have the words for it. But to judge the resident as not caring is not accurate, is what you're saying, right? She, in fact, is caring. She's just privileging one kind of care over the other. And he's potentially about to humiliate her around that. And potentially not help her balance the two, right? To really understand the trade-offs that one has to make in caring deeply, in both ways, in all ways, right? In the urgent, immediate, I'm forgetting the language you use, but in that just in time, just in place kind of way, where right now this woman doesn't want to draw blood because the patient has had enough, but in the long run, in the not so long run future, in the future sense, caring probably what is more important in the longer run is to cause pain and suffering in a minor way in order to kind of pursue the longer, but that's what trainees, physicians have to learn, that complex thought process, right?
And I think what's missing in medical education, it's something I felt very deeply, not because I'm anything special, anything but I really felt that that was missing in my particular education, was that really it is horrible to what we sometimes do to patients. An appendectomy is, a laparotomy or a thoracotomy. It's awful. You wouldn't. It's really, really terrifying what we do. It can be painful. It's disruptive, and definitely. I'm in a job now where we give chemotherapy, and it can be really, really awful for the patient. But even giving a diagnosis, even telling someone they have a new disease is really, it is, and you use the beautiful word humiliating, which is something I would have liked to bring in from Heidegger, but the humiliation comes from the word humus, like earth, like humus, the earth, and it really is the knowledge that your body is a body, is finite, comes from the earth. So in a way, disease is already quite degrading, humiliating, and what doctors do is they participate in it,
right,
and then guide you out of it. But
as humans, right, as part of their being, they participate in
absolutely
very, very difficult things for good reasons or not. As you started, right? You started by saying, there are high-profile examples in modern history of physicians doing terrible things for the wrong reasons. It's interesting to me, you also say that you're arguing for the place of philosophy in this, in our healthcare education endeavor. And I love that you said that it's not really to teach categorical determinations, right, of what's right or wrong or good or bad. In fact, that's been the role of philosophers in medical education for the last 50 years or so, in what we would call a very narrow biomedical ethics frame, where there's a very deterministic kind of approach to, is it right or wrong to introduce yourself as a physician when you're not yet a physician? Is it right or wrong to withhold or withdraw life-saving care? And students get the sense, those who haven't studied philosophy or really don't have a philosophical orientation, that that's the role of philosophy in medical education. And I agree with your argument that it's not about the categorical determinations, but about the ability to ask the right questions in the right moments. And so I'm wondering, you're a little further along in your education now, and you're starting, you're in this, I'm hearing that you're in a consultant role of a hematologist, or you're training.
No. I
Not yet.
No, I wish. I started right back down at the bottom again and work my way up. I was in research, vaccine research for a little bit.
So let me ask you about this. So you're right in the middle of your training, really, right? I mean, you're still becoming, right? I mean, you're becoming a physician, and you're in they're deep in the active education frame. You said, I love this analogy. You said healthcare education is a cake, and care is not just one of its ingredients, but the laws of chemistry that guide the baking process. I think that was a nice way of saying we have these hidden, these foundational ideas that we should care, and yet they're so hidden, they're so fundamental that we don't have words to talk about them. And so talk to me a little bit about what it's like to start giving chemotherapy to somebody to stop a cancer from taking their life or ending their life early. How do you think that through?
Well, that's a good question again. I would say I've read quite a lot sort of in this way, and as you just pointed out, these things are, we are trying to deal with very ambiguous concepts because they're still sort of implicit in the way we deal with everyday medical life. There's a lot of I would say that the general consensus is that we approach it like according to the guidelines, with a diagnosis which is matched with a treatment. And I think externally, if you were communicating to another hematologist, for example, they might give you the answer, look, I simply just go through the process and I simply give chemotherapy that's needed. But, for instance, we had a patient who was for a smart drug, these new monoclonal antibodies, as well as chemotherapy for his treatment. And he would consent to, he said, he was a very, very educated man, said, I want the monoclonal antibodies, but my father had chemotherapy and suffered greatly until he died. And he refused the chemotherapy part. So now there was this kind of, we can't now go according to the guidelines. The guidelines are clear that you need the monoclonal antibody and chemotherapy. But now he's only consenting to one. Can we give it? And it was, I wouldn't say chaos in the department, but there was so much energy expended into trying to navigate this that there must be something else at work. It can't just be, oh, they won't consent to this, we'll just do this. Kind of cold-hearted pragmatism, just do what we should.
And you're saying that the language they use to speak about making those choices is actually blaming the patient.
Yeah, I would say that does happen. Yeah. And I think what happens is that this process, this kind of formalization becomes very bureaucratic. And bureaucratic, as those beautiful films. I didn't know if you saw Brazil, that beautiful film by the old Python.
Sounds like a film recommendation on your podcast area. Brazil, yeah.
And of course all of Franz Kafka, the trial, etc. The bureaucracy is never just the bureaucracy. It's kind of a spiritual process. It's immediately spiritualized, and so when you see these kind of events happen that are so disruptive, it's a patient saying, I want that and not that. And it took 3 weeks for the doctors to find, okay, fine, we'll do that and not that. So in a way, that's what I'd like to unearth, what's really at work. And just by making that explicit, that's what I would hope to show, that there might be another way of doing this, of thinking completely about health and disease. So when you say, what's it like to give chemotherapy? I would say, I really can't stand cancer. I don't find it interesting at all. I find it really despicable. I find it's mindless. It's just the cell that's dividing. I hate it. I can't stand it. I have no romantic, I feel that I'm fine exterminating it. And if it's gone, if I never had to work a day in my life because disease was eradicated, I'd be fine with that. So I do my best to not spiritualize the way the process of a disease happens. I try to keep it in mind that the disease is mindless. And so chemotherapy is a kind of, it's a destructive force, and that's my responsibility. So on one hand, I'm not in control of who's going to react badly, who's going to die of the chemotherapy, but it's still my responsibility, even if it's the patient's consented choice to go ahead with it. So I would say that's kind of, it's somewhat of a tragic position, I would say, or I hope, but
it sounds very tragic and heroic at the same time.
Well, maybe
right?
Heroic.
Well, in that you need to have a mindset that you are in some kind of battle against evil, right? You said that, which is why I'm right. I guess somebody could speak up for the cancers that we kill, but generally we see them as uniformly evil. What I'm trying to get at here is, you talk in the paper a little bit about the fact that becoming a physician is not a mechanical formulaic process, right? As you said, and the practice of medicine is also not a mechanical formulaic process, although we are, for all sorts of good reasons, trying to, manualize the treatments of certain kinds. We want to make sure there's some standards around what we know are best practices. But what then you go on to say is that becoming a physician means really acknowledging and embracing the fact that it's an immersive and reflective process, right? Like it's in all that complexity, the most important thing we can do is immerse ourselves in thinking about the implications of caring in this situation. Like, you care deeply in a negative way about cancer, right? In a very negative way. And I guess, the other thing you go on to say, and I in my field, in trying to think about medical education as instilling as much character in a positive sense and caring in the individuals who are on this journey to becoming physicians, that they can survive these very difficult situations where decision making is so complex. One way to do that is to just ignore the complexity. And another way is to engage with it. And you've chosen to engage. In this case, with the philosophy of being, right? Of being human. And I guess I really want to hear, how, one of the things you say is that of our trainees, we demand that they are sufficiently motivated to care about becoming competent healthcare professionals. Like you said, you're on a mission, right? You're on a social mission initially, right? Because you recognize that social inequities are not given privilege in our training, right? We're not, more and more so they are, by the way, but certainly not ubiquitously around the world. But they're always there. It's always there. And it's always part of the calculation. And you could ignore it or you could engage with it. If you engage with it, the challenge is how to remain capable of functioning.
Yeah. So there's sort of two kind of ways of going about it that I was uncovering in my reading, and the one was really difficult to unearth in the primary text about medicine. As you said, up until sort of maybe 10 years ago, it's mostly been the position of philosophy in medicine has been, what is right, what is wrong, as you said before.
Right.
But there was this article that came out, and I think it was about 1998, which was fascinating. I loved it. But it was a man who was arguing. He said, do doctors even need to care? What if we had imagine this great doctor, young woman, comes in every day, does her job, is kind, is ethical, but when she goes home, she does not care one bit about her patients. She has no second thought whether they live or die, but she still does her best to treat them. And I imagined that for a second, and I thought, if you're in a perfect system, a system that catches all of your little mistakes, a system that has everything you need for the patient. The patients can pay for their own medication, investigations, and you don't need to care. That might be true. The system is so built up around you that you're completely relieved of the responsibility. But I couldn't imagine working in an environment like I was, and if you didn't do something for a patient, they would die. It's simple as that. If you didn't go and prescribe the medication at 4 in the morning, no nurse was going to just double check that you had done it. And so that kind of social paradigm, that kind of looking at the broader picture, that kind of looking at ethics, I wanted to bring all that together and say, all of this, everything is care. Everything can be looked at like this, with this temporal structure. You do a test, you do a blood test because you want to know where this disease is going. But for the same reason, you might hold back on an investigation because there's no value in it. You might find something that you're not going to treat anyway.
Or the trade-off for the patient might be too much, right?
Yeah,
so you might hold off on doing something, right?
But you see, this is the kind of lens of care that I was trying to bring all this together with. And of course, that task is far too big for one paper.
No, and you try, yeah, no, I do appreciate that. You took on a lot in this paper. One of the things you talked about, I want to ask you about God terms here. You say that thinking about the education, you want to think about the education process as a caring process. That's almost never emphasized. That the agency of the actual individual becoming a physician is often not involved in the philosophical debates, right? We don't think about the physician as an agent in that case, where the physician has to make very difficult decisions and ask the right questions in order to make those decisions. But there's some kind of external set of principles that somehow are, should guide all great decisions, as opposed to the humanity of the person. So, and you also distinguish between intimate and assertive caring. Talk about that a bit.
Oh, to be honest, I think that may be one of the weaker points of our paper, but what I was trying to get across there was really that care can be intimate, like it can be between two people, between a mother and a child. I think that was the example we used. But yep. Care could also be, organizing an urgent MRI for this patient who suddenly can't walk. So it was really the kind of texture of the event and what we were facing. And I was really just trying to say that these are two sides of the same coin. They're both care.
In the United States, I don't know if this is true around the world, but you can help me. In the United States, because healthcare is so commercialized, mm-hmm. there are billboards on the highways that say, "We care."
Yeah.
I think you actually even mentioned it in
that
the
was
paper,
one
right?
of our inspirations.
Yeah. There's banners, we care more. No, we care more. There's some competition. And so I guess I enjoyed thinking about the intimate caring versus the assertive caring, right? The system can assertively care for patients. They can either do the right thing, facilitate the access to certain kinds of testing, certain kinds of treatment for all people evenly, despite their ability to pay. Those are principles. But a physician can also engage as an individual in assertive care. Like you said, you could stay longer, go out of your way to get that MRI or the CT scan when somebody otherwise can't do it. Or you could go home and say, I did my job, right? And I cared, I was kind, I was intimately caring, I was a good person, but I didn't assertively care in that situation. And we don't always help people distinguish between those two sides or the two extremes, right? They're not two sides, it's kind of on a continuum. You also say in your paper, and I want to ask you about this, you use the word spirit saying that care is the spirit of medical education, of health care education. It seems like another one of those words, spirit.
Yeah.
I'm wondering where that came from and why you felt the need to kind of spiritualize the role of care in health education.
I think, Maria, correct me if I'm wrong. I think I really want that word in there. I think it was more along the lines of the way Hegel uses the word spirit. Hegel uses the word spirit in the sense of human-minded activity. And what's really what this whole process boiled down to, for me at least, when I was sitting in my room frustrated at why I couldn't say the things that I wanted to say, sort of came down to this attempt at a Hegelian way at looking at medical education. What are its presuppositions? So what does it assume before it can even start? And so it was kind of a nod to that underlying medical education is human-minded activity. That is to say, values, principles, institutions, the reification of these values and groups and institutions they all kind of work together in some way. That doesn't mean there's no contradictions between them. Doesn't mean they don't have opposing
There's a lot of
values.
Tensions, right? There's a lot of tensions, as we've talked about.
Oh,
yeah.
Absolutely. And so I wanted to try and nod, give a little nudge to that's what we were aiming for. So I wouldn't say it was aiming towards spiritualization, in a sort of in a colloquial sense, but more towards this kind of spirit.
It made me giggle just to see it in there, because I realized that talking to true philosophers, people who really want to think deeply and with humanity around these things. I think that I like the use of the word. I just want to give you
I like these titles that these words that can have multiple meanings, all of which are valid. We could say essence as well.
Yes.
But in the context of what we're trying to say and Heidegger's philosophy, it's existentialist. Then you can think of spirit as something that gives life to something.
Mm-hmm.
But even I think connecting it to spirituality would be okay if you, I have this quote by Laszlo, Goff and Russell, where they say that spirituality is a private matter reflecting the relationship between the individual and the cosmos. So if you think very deeply, what is my relationship to everything?
Yeah.
Like we could think, what is the most basic thing we could say about healthcare education and how does it relate to trainees and everything like that? And whether if you say, well, I'm a materialist, I only believe that what I can touch is real, that's in that definition, that's a spiritual attitude, but it's a very basic attitude to not just to life, but to everything, to death as well.
We won't have time to talk about ontic and ontologic, but it's sort of you spend some time in your paper, really exploring these fundamentals, these fundamental ways of looking at the world. I agree with you.
Can I say one thing about that?
Please.
Well, Heidegger is notoriously difficult, and we tried not to use any of his, hyphenated terms and everything, but we thought, okay, this is the one distinction we have to put in there. Ontic is basically beings, so things, entities, you could say, categories. You could say a human being has 2 feet, has certain type of DNA, everything like that. That's ontic, and ontological is relating to being. So what's very distinctive about Heidegger's Being and Time is that he says we've been focusing on the ontic a lot, but we have forgotten about the ontological. And I think it actually relates to something that is happening in medical education, for instance, around professional identity formation, where people are saying we shouldn't just focus on what a physician or a healthcare provider, what what he or she does, or what they think, or what qualities they have, but also their being. So then we're asking them to relate to their being. And that means if you think about what kind of doctor do I want to become? That's actually that's an ontological question. It's also a spiritual question, because you have to think about, what does a doctor do? Not just a doctor in general, but me as a doctor, what can I contribute to this? So that's kind of the level that we try to go to. And then I'm speaking way too long about this, but the idea is that we've been focusing on ontic manifestations of care. For instance, you can say the healthcare system as an economic and logistical system, and caring as empathy. And those are ontically, they're completely different things, but ontologically, they're part of the same care. That's what we're trying to say.
Yeah, I think it was again, I encourage the listening audience to read the paper in detail, because you do very simply describe why that's important. Certainly I didn't understand it before reading it. I now do. And I think it's very important. So in this last couple of minutes, can you, either of you, talk about what you're hoping putting this paper out into the world will bring next?
I have to say this paper is very special to me. Of course, all of my papers are special, but I've been studying Heidegger for 20 years, and I've been working in medical education for a little over 10 years. And for the first years, I was doing my medical education job, and in my other life, I would do philosophy. And I never thought I could combine them. Well, Anna Cianciolo is the editor-in-chief of Teaching and Learning. She gave me this opportunity as well. But then a couple of years ago, I started thinking of this idea of looking at being and time and making a direct line to medical education. But I didn't think it was possible to do that inside of the genre and the culture of the medical education journals, until I met Camillo. It was, what is it now, 2 years ago or something? And I thought, okay, we can do it together. Mm-hmm. So what I'm hoping to achieve, first of all, is that people read the paper, and it's really meant to get you to think, to ask questions, and hopefully people will also criticize it and disagree with it. But I hope people will engage with it. That's my hope. And
you, Camillo?
Well, I was just pleased to hear the name of the institution you work for. I believe with the transformation of medical education. Is that correct?
I'm going to do a little plug here. It's the Robert D. and Patricia E. Kern Institute for the Transformation of Medical Education at the Medical College of Wisconsin. And we're very, very interested in exactly what you just described and the work you're doing in that we don't feel we can move forward in meaningful ways without engaging with the deeper questions, the more important questions.
So I would say, in transforming medical education, I would hope that moving forward in the way we think about medical education, we can start to teach students not only, how to appear as though they're caring, or to have an internal experience of what they think care is, but really to, when they're faced with a kind of choice of a very material kind of procedure related, something related to process the normal procedures of everyday life, or that they could do something else, something more, that they could argue for both ways. And I think if I could give an example, I would say it's very easy to do a daily blood test on a patient and see their creatinine slowly creeping up as they die. And if they're going to die, it's very easy to just let go and do the daily blood test. But it's very hard to go to the patient and tell them that they're dying, or to go to the family and explain. It's quite easy to sit back. And I think that attitude of sitting back and just following the process, that's where the humanity gets lost. So I would say, just if students, if junior doctors could start to really argue intellectually for these things that are softer skills, I put in quotation marks, if they could argue the principles and the importance of those things intellectually, that we can really change the way medicine appears to the public.
This has been really wonderful to get to read you deeply and then to talk about some of these ideas. We could go on for a long time.
Yeah, for sure.
And I would love to go on for a long time, but I encourage you to keep thinking this deeply about this particular topic. There's a reading audience, I can promise you, that is going to engage with you.
Yeah, thank you so much. And we talked about care now, but it's actually what we're trying to do is to encourage people to think deeply about the fundamental concepts that we use in medical education. And I think we're in the same mission, what you're doing around the concept of character. Yeah. Really just think deeply about what are the words that we use every day, and see where that leads.
We might have to go back to Aristotle for that one.
Thank you so much.
Lovely to meet you too.
Yeah, thank you.
Thank you for listening. I did an episode with Camillo for my other podcast, Live from Plato's Cave. It's an interdisciplinary philosophy podcast, and the episode with Camillo is called How Doctors Think. So if you want to hear more from us, check out that episode. You can find the link in the description.